So we're now here from our second panel, who will provide an overview on the National Academy of Public Administration's report, The STD Epidemic in America, the Frontline Struggle. This report was released last month and is the second NAPA report commissioned by the National Coalition of STD Directors, whose perspective we'll hear about in this panel. For this panel, our panelists will have 15 minutes to present, and again, 20 minutes for Q&A. Our speaker, who is remote, is Dr. Georges Benjamin, who is the Executive Director of the American Public Health Association, the National Academy of Public Administration Study Fellow, and the chair of the panel that authored the report. And as I mentioned, Dr. Benjamin is on remote, so please feel free to start, Dr. Benjamin.
Hi, everyone. So let's go to the first slide there. The next slide, no, I don't really have any financial conflict of interest. I know the panel's interested in that. So here's again, we did a two-part study. I know the committee had heard from one of my colleagues at your last meeting around the first part of the study. I just want to review that very quickly. Next slide. So the study panel is essentially the same group that did the first study, myself, Ken Kaiser, Greg Payne, Shoshana Safir, and Bill Jimson. And the study team with a few different folks. In addition, we had some support from a group of fellows at the George Washington University who looked at some of the financial metrics that we did. Next step. So as you may remember, the phase one focus was to kind of look at the national level from a bird's eye view and kind of looked at the state of the STD epidemic, looked at federal programs, looked at prevention and control efforts, and really began trying to look at national promising practices to address the epidemic. We also knew that Brett Gerard, the Assistant Secretary for Health, is working on a national STD strategy. So we met with them, and the idea was, of course, that this results would help inform the federal strategy as they put that together. Next slide. So the findings from that one is certainly that the way our system is currently constructed does present some real challenges for STD prevention, treatment, and control. The fragmentation of our public health system, across the government, continued insufficient funding, funding constraints at really all levels of government, emerging challenges in data collection and analysis, and something, of course, you're aware of, the interoperability of our electronic reporting systems. As Bob Redfield would call it, that we're data archaeologists in terms of the timeliness of our data. Obviously the changes in the insurance marketplace and a lot of issues around who has the data and who has access to it continues to plague our efforts. And frankly, unlike HIV and AIDS and even to some degree chlamydia, the other STDs are pretty much still remain fairly well hidden. And stigma, of course, about who gets it and who's at risk for it, and a general lack of understanding of why these tests are done, even for someone, quote unquote, who is then reported as not being sexually active by their parent. From the last question that you were asked there. So we did this report, and let me go on to the next slide. And so in that report, we had these following acts of consideration. We felt that at some point, there has to be somebody who wants to speak out on STDs. The need for a national champion to talk about this issue is more relevant than ever. We need to think about changing that narrative and reframing it as a component of general health and wellness to try to deal with the stigma issue. Continue talking about unifying the field because, again, we get all of these diseases in general through the same mechanism. It's sexual contact and or IV drug use. And then, of course, diseases or substances that result in alteration of mood. So people who drink a lot or are using drugs also may be more at risk because of the fact they're in an altered mood. We talked about in the first report about better data and education and awareness, and of course, encourage funding be improved, recognizing the scale of the epidemic and its growth was important to, as an advocacy point to increase funding for STD prevention and control. Next slide. So our second focus was to get off of the global national level and try to get down into the state and local issues and address this. We really did not address Native American populations, although you may see them mentioned here and there, and we didn't really look at the territories more specifically as part of this report. Next slide. So as we looked at the scope, we pointed out that the steps we needed to really help the nation build a more action-oriented and strategic plan was one of our goals. So we wanted to get a little bit more information, particularly at the local level, to enable that process. We talked a lot about, as we looked at the scope, looking at frontline programs, looking at the burden placed upon state and local authorities as a consequence of the epidemic, tried to trace some of the funding streams to facilitate those programs and the authorities that went with them, looked at some of the intergovernmental obstacles to actually executing the programs, recognizing there's an administrative burden, identified all kinds of conflicting policies and funding constraints. And the part of the scope was also to develop a set of actions for consideration, again, to help inform the federal plan, recognizing that for all practical purposes, a lot of this is driven at the federal level. Next slide. So we consulted with the folks that actually do this work for a living, so NCSD, NACHO, ASCO, talked to the Big Cities Coalition. As you know, the Big Cities Coalition is the coalition of the larger city health departments. And in doing so, we also wanted to identify some real jurisdictions to actually look at. So we looked at jurisdictions, Louisiana, Massachusetts, Missouri, North Carolina, Utah, and Vermont. And we tried to get a geographic representation there and also relatively different size health departments. We also looked at an additional 5 jurisdictions just to get a quick snapshot to kind of further highlight their challenges and some of the notable practices. And those you see there, Arizona, Rhode Island, Tennessee, Washington, and Philadelphia, as a way of trying to look at those of their programs. And we picked those based on a series of metrics: how many STD cases they had, their prevalence rates. So we had some that were high, middle, and low in terms of their rates. Looked at their governance structures, looked at the status of their Medicaid expansion, and geographic demographic composition played some role in why we selected those places. Next slide. So, obviously the first thing you want to do when you do one of these things is make sure what you said the first time makes some sense. And again, we clearly, found that the health system was highly fragmented. Again, that's not anything that's not new. And the varying points of access to care and payment structures. Again, you've seen one STD program, you've seen one STD program, you've seen one health department, you've seen one health department, but there are some commonalities across all of those entities. Next slide. In terms of our findings, at the end of the day, money, money, money. The STD infrastructure is grossly underfunded and under-resourced. The federal government primarily is the driver of funding for STDs. There's certainly some additional local money that goes into that as well. But the major funder for these activities and the driver for this still appears to be at the federal level. That the siloing of these various programs continues to be a problem, although there are jurisdictions that have found ways to reduce the siloing effect. And you'll see that in some of the case studies that we have. Staffing resources are desperately needed, particularly with disease intervention specialists, who, of course, are the people that actually go out and do the work of disease investigation and contact tracing and linking people to care. That seemed like one area that was grossly needed. Next slide. And obviously the differences in the way these programs are structured is important. But I think the more important thing is the need for more program integration between the whole range of STD programs, HIV, hepatitis, TB. There is integration that occurs for sure, but there's still barriers to sharing resources, sharing financial resources in particular, even an individual person sometimes is a challenge when they're, of course, as you know, seeing some of the same populations. The public awareness part, not only at the national level, but at the local level, where the rubber meets the road, remains a big issue. And again, to reaffirm the stigma continues to be a big problem. Next slide. So we had a series of recommendations for this work. We basically had four big buckets. The first one was that the need for federal funding reform to improve program agility across the programs, allow people to move monies around more easily, particularly to address growth and outbreaks that they may see, and looking to re-silo some of the federal funding that occurred. Note that we did not say block grants, but we did say trying to break down some of the silos. Secondly was to expand access to care. Clearly, those states that don't have a system with everyone in remain challenged. In those areas, the brick and mortar STD programs certainly are much more prominent, but as you heard from your previous speaker, the general public also tends to go to some of the STD programs for a variety of reasons. So this really is a population-based system that needs to be supported for everyone and not just targeted populations. Everyone ought to be able to receive services there through a variety of ways, and to the extent we can create one-stop shops, we would advocate for that strongly. Next slide. Recommendation number 3 was around data, recognizing that we really still haven't built the technology surveillance systems that we need for the future to allow rapid transmission of data. Those of you who were practicing clinical medicine, certainly 30 years ago, remember the old STD cards that you fill out and you drop them in the mail, and they'd eventually get to the health department, and then somebody would go out and follow up on that case. And even though we have electronic data systems, I'm not so sure that we've progressed much beyond that system. A lot of times that data is still getting picked up because of a positive culture in lab, but the systems really aren't as real time as we really need to really address an epidemic of the nature that we have today. And then the need for better education, really a national education campaign around STDs is very important. You know, it's a shame that we've certainly made enormous efforts on HIV and AIDS. We're beginning to make some efforts just early, I think, in chlamydia, but syphilis remains a word that people just refuse to talk about. Nobody believes that they are at risk. Gonorrhea, of course, continues to be a real challenge, and in light of the amount of drug resistance we have out there, we still think it remains a major public health risk. Remind you that this panel, even though there are lots of docs on the panel, is not a group that looked at the health, broader health implications. We look mostly at the management of those systems and not necessarily the health, although obviously we were informed by the fact that almost everybody on the panel at some point had practiced public health at some level.
Thank you, Dr. Benjamin.
Thank you.